Welcome again to part 2 of heart failure in infants and children. We have been talking about the causes of heart failure, the pathophysiology, the investigations, and now we're going to talk about the treatment of heart failure. The number one step in treatment is to treat the cause. The patient might be severely anemic or lost blood, and that's why he's in heart failure. So we give blood. So to correct the anemia, treat the infection. If the patient is in carditis, treat accordingly. Or maybe there is a congenital or valve lesion that needs to be surgically corrected for the treatment or complete management of heart failure. The general care, the patient has to rest and to reduce the cardiac output. The patient, if he put him in the semi-sitting position at 45 degrees, this is better for his respiration. And in infants, we ask the mother not to make their babies lie flat, but to elevate them in a semi-sitting position. We can use oxygen to improve oxygenation in the presence of pulmonary edema. Restrict the sodium and the fluid so as to decrease the vascular congestion and decrease the preload. What are the drugs that we use? Number one, we use diuretics. The most commonly used and the most popular is the furosemide, the Lasix. The furosemide decreases the preload, the afterload, and it treats hypertension. The usual dose is 1 to 2 milligram per kilogram. It is either given by IV, intramuscular, or oral, and then we can increase the dose later on. This is the rule in diuretics to start with furosemide, but there is loss of electrolytes with it, and that is why we frequently add it with spironolactone, because this spironolactone is an aldosterone antagonist, and it preserves potassium. It doesn't lead to loss of potassium in urine like diuretics, like the furosemide, so it preserves the potassium, and is given in 1 to 3 milligram per kilogram per day in divided doses, and it can be added to the furosemide to potentiate their action together. Inotropic drugs, the most popular of which is digitalis. Now we have to understand that digitalis, although it's a very good and effective drug, it has a narrow spectrum and toxicity can occur from the therapeutic dose if increased, and many iatrogenic problems occur. Iatrogenic means doctor-induced, that many times an overdose of digoxin can lead to digitalis toxicity. It inhibits membrane sodium potassium ATPase and increases intracellular calcium, improves cardiac contractility, and increases the myocardial oxygen consumption. The average dose is 0.01 milligram per kilogram orally, divided twice per day. This is a maintenance dose. Now I want you to read about digitalis. This is part of the work you have to do. Please kindly read about digitalis. See what is the dose in the neonates, in the infants, and in a child. In books you're going to find out that it is said that we start what is called by total digitalizing dose, and then we give maintenance. Nowadays we start by the maintenance right away. It is effective and we reach the same target by it. Dopamine is an inotrope that releases the myocardial norepinephrine, plus having an effect on the beta receptors. It may increase the systemic blood pressure, and at low infusion rates dilates the renal artery and facilitates diuresis. It's given between 2 to 20 microgram per kilogram per minute IV, and thus it has to be given in an ICU, and we start with a small dose and gradually titrate upwards. The dobutamine is a beta-1 receptor agent, often combined with dopamine, and that is its dose, and we usually increases gradually as we do with the dopamine. The amrinone and the milrinone, they are non-sympathetic, non-cardiac glycosides with inotropic effects, and they may cause vasodilation, and they have very good effects on patients with severe heart failure when we find that the other inotropes are not effective. It is particularly used in the post-cardiac ICU. The afterload reducing agents, on the top of which and the very popular is the captopril. The captopril has led to a revolution in the treatment of heart failure. It inhibits angiotensin converting enzyme inhibitor and reduces angiotensin II production. And after its use and after we introduced it in the treatment of heart failure, it prevents the cardiac remodeling. Many patients were saved. يعني الحقبة اللي قبل دخول كابتوبريل كنا ندي الانتي فيلير ميجرز لازكس والديجوكسين يحسنوا symptoms بس العيان الميوكارديوم بتاعه ما يتحسنش. But if you give captopril early, it prevents the cardiac remodeling and the patient has got a better chance of controlling his heart failure. And these are the doses, please kindly read them. In average, we use the 0.5 milligram per kilogram, even per day, or it can be increased per dose. The nitroprusside can be used and is both an arterial and venous for arterial and venous relaxation and it's a venodilator that reduces the preload. In cases of intractable heart failure, ventricular assist devices are used. They improve the ventricular function. Ventricular assist devices are devices that improve the contraction of the left ventricle. Cardiac transplantation, though not easy, of course, to find a donor, and it's the process not present in every country. Extracorporeal membrane oxygenation to bypass the heart and improve the functions after surgery, and then the patient is returned to the normal cardiac circulation. Beta blocking agents like carvedilol can also be added, and they are frequently added in treatment of heart failure, and they actually do give good results in some of the cases. So kindly read the references, be ready with your questions in the next face-to-face session. I have given you the references and the books from which you read, the Nelson textbook and the current textbook, the Essentials of Nelson and the current. Please read the pediatric cardiology from these books and prepare your questions for the next face-to-face meeting, and good luck.